DMOAD, disease modifying osteoarthritis drugs. So very new term, and in last few years this has been most discussed and debated topic. As the name suggests, DMOAD or disease modifying osteoarthritis drugs, they are supposed to not only give relief to the patient in osteoarthritis patient obviously, but they also will change the pathophysiology of this disease, resulting in halting or delaying disease progression of osteoarthritis. So as it sounds, it sounds to be very promising drug. So whether these kind of drugs are really effective in osteoarthritis or not, that is one question. Secondly, if they are effective, whether they should be prescribed in our day-to-day clinical practice or not. This is the second question. So on this very important topic, we have two eminent speakers. They will debate on this topic. First, in the favor of this topic, Professor Kshetramadhav Ghosh is going to speak, and against Professor Kshetramadhav Das, who is head of the department of PMR in Bardhaman Medical College, and against that this topic, Dr. Madhusri Sengupta, consultant physiatrist of NH Mukundapur, is going to speak. Now I would like to invite Professor Kshetramadhav Das to come on the dais to speak in the favor of this topic.
Thank you for inviting me. In the year 2003, I started my research work on doxycycline. At that point of time, that was the only DMOAD, candidate DMOAD, and that was the second human study in the world. So today I am talking in favor of who else will talk in favor of this motion. So I welcome you all to this debating session, and I am here to speak for the motion. And the motion is: management of osteoarthritis essentially involves disease-modifying agents, DMOADs. But I'd like to draw the attention of the scientific committee that whatever we write in full form, only the abbreviation form of that can be used in the parentheses or bracket. So it's a minor error, it's a nominal one, but I know I'm just trying to draw their attention, and after doing that and taking everybody's permission, I think the DMOAD is, as it stands for disease-modifying osteoarthritis drug, as our chairperson has already elaborated. So today our topic should be disease-modifying osteoarthritis drug. At the very beginning, I'd like to question the audience. I need one answer. My question is very simple. How many approved DMOADs are there at the present moment? What is the number of DMOADs approved by the regulatory authorities? Come on, please. I didn't get a single answer. Oh no, paracetamol is not considered as DMOAD. Any more guess? Any more answer? No, it is not approved as DMOAD by the regulatory bodies. Yeah, that's the right answer, because he must be knowing it. And so the answer is a big zero. Does that mean that I am surrendering right now? Does that mean I am giving Madhusri a walkover? No, certainly not. Because in spite of knowing this thing, the academic subcommittee has kept this as the motion of the debate. Only because science, any branch of science, including the medical science, doesn't concentrate only on the immediate present. Any science, any branch of science, including medical science, have its futuristic vision. And for that, science progresses. Without that, humankind cannot get the benefit of medical science. And that is the reason I agree fully with the motion that the management of osteoarthritis essentially involves DMOADs. Why? If you look at the pathophysiology, pathogenesis of osteoarthritis, we know that it involves different molecular and different cellular events. And also some biochemical, biomechanical, and inflammatory cascades are initiated, and it involves almost all structures of joint, intra and peri, in and around. The meniscus, ligaments, synovium, of course the cartilage, the most important thing, the most discussed one, and the subchondral bone, even the nerves, proprioceptive nerve, the periarticular muscles, everything, and all these. And to tackle all these, what we need? We need DMOADs. Gone are the days when the entity was called osteoarthritis, because at that point of time it was believed that it's just a simple wear and tear disorder. But nowadays we know it's osteoarthritis because it involves inflammation, though it is mild to moderate and locally inflamed, but inflammation is there. So osteoarthritis is now recognized as a chronic, progressive, whole joint disease characterized by biochemical, biomechanical and inflammatory alterations involving almost all the structures intra and periarticular. So given the multifactorial pathophysiology, it is increasingly evident that effective management must extend beyond symptomatic relief and target the underlying mechanism of disease progression. This paradigm shaped positions DMOADs as essential components in contemporary and future way management. OA pathogenesis emphasizes the need for disease modification. The traditional way management is centered on just analgesia and functional restoration, but it overlooks critical structural drivers like upregulation of matrix metalloproteinases, ADAMTs, enzymes leading to cartilage matrix degradation, low-grade synovial inflammation mediated by interleukin-1 beta, TNF-alpha, alarmins, altered WNT beta-catenin signaling contributing to subchondral bone sclerosis, chondrocyte senescence, oxidative stress, impaired autophagy, etc., etc. But the DMOADs target these molecular and cellular pathways, and thereby they influence the disease trajectory. And that is the reason, as therapeutic aim is to influence disease process rather than merely masking symptoms, DMOADs involvement becomes indispensable in the management of osteoarthritis. Symptomatic therapies do not alter the natural history of osteoarthritis, as everybody know. Analgesics, NSAIDs, and intra-articular corticosteroids provide short-term pain control, and they lack evidence for structural benefit. Even the long-term NSAIDs use carries the risk of higher chances of systemic toxicities. Repeated steroid injections may actually accelerate cartilage loss. Viscosupplementation effects remain inconsistent, short-lived, and largely symptomatic only. So management that fails to slow structural decline cannot be considered comprehensive, and for the comprehensive management of osteoarthritis, disease modifiers are required. DMOADs align with modern therapeutic goals, slowing or halting progression. Actually, this is the goal for each and every disease, not only the symptomatic relief. It cannot be so. DMOADs aim to reduce catabolic enzyme activity like ADMTS5 inhibitor, M6495, a candidate DMOAD. Enhance anabolic repair pathways like FG818 agonist such as sprifermin. Modulate inflammatory mediators via interleukin-1 inhibition such as canakinumab, and also one drug which was never approved but was very popular, you told, diacerin. And normalize subchondral bone turnover, WNT pathway modulators such as lorisivivint. They remove senescent chondrocytes in the form of senolytics like UBX101, another candidate DMOAD. So mechanism of action of DMOAD is aligned directly with the pathophysiology of OA. So there should not be any doubt that DMOADs are there at the central to pharmacologic management of osteoarthritis. The emerging clinical evidence supports the central role of DMOADs. Sprifermin, the FGF18 agonist, increases cartilage thickness when administered intra-articularly. Lorisivivint and SM0490, both WNT pathway modulators, shows clinically meaningful structural outcomes in different subsets of osteoarthritis population while injected IA, and the lorisivivint doesn't show any significant adverse effects in human studies also. It's a very promising one. strontium ranelate has shown slowed radiographic progression in EOA, but the drug has been withdrawn even for osteoporosis. So I'm not going into details of that. And the senolytics, UBX101 and tanezumab, the anti-NGF biologic, shows promises as modifying disease processes. They have shown promising results in animal studies. The clinical trial is still ongoing, but the tanezumab has some severe adverse effects, like even the osteonecrosis of knee joints and something like that in human studies. So we should be very careful at the same time. So this is the long list of all the DMOAD studied in the literature. And this long list, this robust pipeline indicates a scientific consensus towards disease modification as the future of principal OA pharmacotherapy. The ultimate goal of OA management is to delay, prevent joint replacement. And DMOADs exactly do that. They slow the disease progression, thereby increases the preoperative window, reduces the percentage, prevalence of surgery, and reduces surgical burden. DMOADs also align with patient-centric care demands, because patients always want, the long-term improvement and also the restoration of the function, the preservation of the function, and that can only be achieved by DMOADs, not by the symptomatic drugs, which gives only a short-lived symptomatic relief. My time may be deducted from the next 5. Okay. A disease-based model of OA management necessarily includes DMOADs. Why? Because we have seen into the pathophysiology of the disease, and we have seen that they are actually altering that pathogenesis of osteoarthritis. So DMOADs are fundamental to evidence-aligned management. Still, definitely, the question will be raised. The question is often raised actually, if there is so much evidence, if there is so much research, if the list is so robust, why not even a single DMOAD has been approved by the regulatory body yet? So yes, the fact is that there is disappointment about DMOAD, but the cause, the failure might not be lies in the DMOADs themselves. It may be in a different reason. The cause is mainly because of the therapeutic limitation and the efficacy limitation. And the therapeutic limitation, the root cause is short intra-articular half-life while administered locally, and increased adverse effects when administered systemically. And both can be solved by the appropriate drug delivery system, which I am coming to later on. And the efficacy limitation is basically due to involvement of different tissues and pathways, while the disease-modifying osteoarthritis drugs are actually hitting maybe 1 or 2 cellular or molecular pathways. And that can be solved by endotype-specific therapy and coupling it with non-pharmacologic therapy. Because OA have different subsets, different endotypes, and the disease-modifying drug should target that endotype so that addressing a few pathologic process, it can modify the disease. And the non-pharmacologic therapy, why it has to be done? Because we know that everything either starts with the biomechanical alteration or every other process gets accentuated by the biomedical process. So once upon a time, when osteoarthritis is primarily known as the disease of cartilage only, the famous osteoarthritis researcher Dr. K.D. Brand once told that cartilage is not the culprit, but the victim of the altered biomechanics. And now we can call that all the structures are not culprit, but the victim of the altered biomechanics. And to correct that to correct that altered biomechanics, we need to do the disease-modifying non-pharmacologic therapy. So the DMOAD should be coupled with disease-modifying non-pharmacologic therapy in the form of therapeutic exercise, orthosis, etc., etc. These are the main drug delivery system. I'm not going into details, and these are the way endotypes, and drugs are being developed according to the endotype-specific drugs, according to the so that they can be more effective. So, given the complex pathophysiology of osteoarthritis and limitations of purely symptomatic therapy, comprehensive management must aim to modify the disease process, DMOADs form the cornerstone of this approach by targeting molecular pathways, preserving joint structure, delaying progression, maintaining function. Thus, the management of osteoarthritis essentially involved DMOADs stands on strong scientific and clinical rationale. I can conclude like this. Thanks for listening to my arguments, and I hope at the end you will be by my side. Thank you again.
Okay, after such a interesting deliberation, I think Madhusri can bet.
A very good afternoon to all. I'm really sorry I do not have slides, so please bear with my voice. Good afternoon, chairpersons, my esteemed opponent, and the audience. Thank you for giving me the opportunity to express my view. I speak against the motion. Management of osteoarthritis essentially involves disease-modifying osteoarthritic drugs or agents. My problem is not with the word involvement. My problem is the word essentially involves. I respect Dr. K.M. Dash's in-depth analysis of the topic. However, I would like to differ in certain areas. Sir speaks about the science and future, but we are not talking about sci-fi here. We are talking about science, existing science, science in the present. Dr. K.M. Dash said that the whole joint disease, osteoarthritis is a whole joint disease. But in recent time, osteoarthritis has evolved from being merely a whole joint disease to being a disorder, considering the extent of functional limitations. So DMOADs alone or primarily cannot be given the Herculean task of addressing the various spectrums of the disease. Who said they have to be the flag bearers of maintaining the disease? Secondly, although the research on DMOADs is ever evolving, till date, like my esteemed opponent said, no DMOAD is FDA approved. Phase 1, Phase 2 trials of innovative cut-end research like anti-cytokine therapy, gene therapy, enzyme inhibitors, etc., have remained inconclusive. Results are often not reproducible or sustainable. Thirdly, osteoarthritis is a disorder of lifestyle. Obesity, physical inactivity, age are still the highest risk factors or identifiable risk factors. So if anything is irreplaceable or most important in OA management, it is the lifestyle management. I am sure all of us in our OPD have come across perfectly healthy patients who are doing well with OA and they say, we have stopped medication, I focus on lifestyle now. The other is also true. From our neighboring countries, lots of prescriptions we get full of 5-6 DMOADs limping into our chamber. So that proves my point. Finally, if OA remains a disease of symptom management and lifestyle modification, then why should DMOADs alone wear the gold medal? It is a contestant in the race, but not the winner, not yet. In the pathogenesis of OA, there is a role of mechanical, inflammatory, aging and metabolic disorders. So this dysbiotic alteration and stress are the significant contributors to the pain syndrome. Now, in a bipedal stance, if you see, each knee has to support 43% of your body weight, while in a unipedal stance, about 93% of the body weight. Most clinical guidelines will still suggest prevention of weight gain, weight loss at least 5 to 10% for alleviation of symptoms. This can be achieved through diet and exercises alone, along with self-education, and this is still a level A evidence in most systematic reviews. DMOADs do not address these key areas, nor does it address the psychosomatic impact of the maladaptive eating pattern that you develop in a chronic pain syndrome like OA, eventually resulting in more and more weight gain. Euler recommends physical activity as the core management of OA, not DMOADs. I will highlight the guidance. An individualized multi-component plan, which includes education and an exercise program of adequate dosage with an individualized mode of delivery. By this I mean it could be a group therapy, single therapy, a class therapy, depending on what suits you. Maintenance of healthy weight with walking aids like appropriate footwear, assistive devices if necessary, adaptation at work, at home, ergonomics, and behavioral changes to reduce pain and improve functionality. This still remains the crux of management of osteoarthritis. Most of these recommendations still have 1A, 1B level of evidence. Exercises like stationary cycling, tai chi, proprioceptive training, weight bearing, non-weight bearing, all are there. Frankly, more literature has come up in the past few years where an OA patient, there is no one thing that you cannot do. Depends on your functional capability, what your exercise level or what your body structure is. There are even studies that support even running is okay in OA if your body supports it. So it's still a very individualized, and there is no to everything. A physiatrist has a syringe in one hand and a probe in the other hand. So there are myriad of options we have in minimally invasive management. Injection of corticosteroid, which will have analgesic, anti-inflammatory effect. Viscosupplementation with its rheological effect. Injection of PRP, growth factor. Although inconsistent result, but that is probably because there's a lot of inconsistencies in the literature regarding its preparation. Genicular nerve block, radiofrequency ablation, cryoneurolysis are used for pain relief. Patients might be more effective to genicular artery embolization. It is safe, and improvement in synovitis have been reported. And the placebo effect, when compared with placebo, it has been seen that the effect is more. So if we want to be experimental, like a sci-fi movie, then there are a lot of tools to be experimental with. Autologous bone marrow-derived mesenchymal stem cells play a key role. It has been variously reported to reduce pain and stiffness. There is also the off-label use of intra-articular botulinum toxin that has anti-nociceptive as well as anti-inflammatory action. I agree that none of these are FDA recommended, but then not even DMOADs are. One might argue that they are intrinsically DMOADs in the first place. Well, till date, the intra-articular therapies suffer from a big identity crisis, and they are still categorized under regenerative medicine, not DMOADs. As currently no DMOAD exists, the scientific world is now attempting to identify more and more novel cellular techniques, repurpose the existing drugs that's already there. My opponent has already touched those topics: methotrexate, atorvastatin, bisphosphonates. So if we are giving DMOADs so much benefit of doubt, then why not the other drugs as well? OA, we must remember, is a heterogeneous disease, and it is also an endotype-based disorder. So it could be a synovium-based, it could be a cartilage-driven, it could be different types. A PMR physician must not forget the P in their degree. So use of physical modalities like TENS, UST, laser are adjunctive but useful in pain management and improving the mobility. Additionally, advanced technologies are there in our hand. Why not use them? Virtual reality, robotics, AI, they are also being explored. Use biofeedback like EMG to improve the muscle retraining. To summarize, osteoarthritis involves the total joint, like my opponent said. I agree. But one must not forget the muscles which are above the joint. One must not forget the psyche of the person who is having the joint, the kinetics, the kinematics of the person, which is very, very individualized. DMOADs undoubtedly are an area for huge scope of innovation. We agree. It has the possibility in future to destroy OA at the molecular level. But till day, like science is always in terms of what we have today, the results, the consensus, and the options are all suboptimal. No treatment except knee replacement is indicated for grade 4 OA, include DMOAD. Hence, there is no harm in individualizing treatment based on goals of the patient with the other things that we do have literature based on. Until future studies can prove that DMOADs are effective in patients with OA in repair and regeneration, treatment aiming at symptom relief and lifestyle modification should continue. So with this, I end my talk. And I am sure I will have more supporters than you, sir.
Nice talk, Madhusri, even without PPTs.
Nothing new. All of us know that Madhusri, Dr. Madhusri Sengupta, is a prolific speaker with outstanding oratory skill. And with her speaking skill, she can make any yes to no and any no to yes. Okay, like she tried to do it, but I'll just clarify her a few more things. She is talking about that essentially involved, she is telling that it is a simple present tense. But we know she might be a prolific speaker, but even Smriti Mandana sometimes misjudged a full toss and instead of scoring a sixer, gets herself bowled out. Simple present tense often expresses the universal truth, habitual fact. In the night time, when there is no sun, Don't we say that sun gives us light, sun gives us energy? We see it. So right now, DMOAD may not be approved, but if you understand the pathophysiology, if you understand the research, if you understand the momentum, the direction of the medical science, the osteoarthritis management, you will know that this is the universal truth, and you can always use the simple present tense, because simple present tense often expressed the universal truth. And I haven't ever told that, she was telling that I was only concentrating on the DMOAD. No, I was only concentrating at the first phase on the DMOAD because this is the topic today. But I told that even the disease-modifying non-pharmacological therapy has to be coupled with these. So what she was telling, and she was telling that I haven't touched that. Actually, I have touched that, and I have told that if you have to secure your home and you have two doors, I told that everything starts with biomechanics, or every cascade gets emphasized, gets targeted by the biomechanics, altered biomechanics. I have told that too. So if you have a house to keep it safe, and you have two doors, want to block the two doors, want to lock the two doors, and so locking the one door is also essential, locking another door is also essential. But today's topic was about one door, so I was concentrating on that door. Thank you very much. Thank you, everybody, including my opponent speaker, excellent speaker.
Thank you for those compliments, sir. I might be a good speaker, but you are definitely more philosophical than I am.